So a little bit of history. I think Mike thought it would be helpful for those of you that don't sort of know who we are. I'm not going to spend a lot of time on this. We were founded in 1963, sort of along with the deinstitutionalization that was started by President Kennedy. Our original National Council members were sort of those original community mental health centers that were founded to take care of people in the community as they started to, be moved from state hospitals into the community. Sort of our members, our providers were those sort of initial providers. I think the important sort of bullet here is really the last one that really underscores, sort of the range of payers that exist for community-based behavioral health, but in particular the role that Medicaid really plays. As you can see, Medicaid in a lot of places pays for up to 70% of services. And as we'll talk about, I think it incredibly frustrating given that to be left out of sort of the incentives. For the most part, our programs as well as our providers are not going to qualify for those incentives. And I think our members are very, very alarmed and very concerned about what that's going to mean for them. Is it going to mean that we're left out? Obviously our members that have strong psychiatrists and psychiatrists on staff, they think they're going to qualify. But for the most part, we've got a lot of members that maybe they have a psychiatrist once a week, maybe once every 2 weeks, once a month. They service a number of different centers. What does that mean for our providers? We really don't know yet. And I think that's sort of the unknown is also causing a little concern and alarm as well. I think the other thing that's important to point out from the sort of perspective of policy change and implementation is that this is a system that is overwhelmingly publicly funded. The public funds about 60% of mental health services, and on the addiction side, about 80% of all the funding that is put towards addiction is public. And so it's sort of if you think about it, it can present an incredible opportunity to really change policy because the public system is sort of the payer for sort of these safety net services. I think the other thing that's really interesting and sort of represents a trend in the field is the implementation of parity, not only federal mental health and addiction parity, but Medicare parity in S-CHIP. There are some people that are generously anticipating, I think, but that there could be potential for up to a 30% increase in behavioral health spending between sort of those changes in laws. And so that's sort of a trend that is also going on, as well as we're seeing, obviously, inpatient spending is decreasing, has been decreasing for a number of years, and outpatient spending, of course. Sort of what are we doing to deal with people in the community? I think that is obviously always been something that has been at the heart of sort of the community mental health movement. But I think increasingly is a conversation sort of in the addiction treatment world. Residential care is incredibly expensive, 28 days, 3 months, 6 months. And so could we be doing more as community-based providers to really care for people in the community? What are the supports we wrap around them? What are the things that we really need to be done to sort of keep them in the community and keep them connected to their families and those sorts of things? Wanted to give you a sense for sort of who our members are, what services they provide. I know that's probably hard to read, but as I said, overwhelmingly, our providers do specialize in mental health and addiction services, do a lot of work with children as well, but I think also, do a lot of employment, vocational services, supportive housing, school-based services. Our clients are people who are also bouncing between systems. I think that's the other important thing to talk about that was sort of echoed here. Not only are they sort of in our systems, but they're in the child welfare system often. They're in the criminal justice system, and they're in the emergency rooms. They're sort of bouncing from place to place, and there is no ability to capture sort of the data and what happens in each of those encounters. And I think there's a lot of hope that through EHRs and EMRs, we could start to really capture what's really happening with these people. You could really track sort of their movement. What did happen in the emergency room? Did they just get, they got a bed for a night to detox, and then they were, good luck, see ya, no connection to specialized services, and vice versa. So I think our members operate in a range of different systems. And two, I think on the bottom, primary care, I think is another increasingly an area of interest to our members. We have spent a lot of time thinking about how do you really marry primary care services with behavioral health services. How do you partner with the community health centers, whether they're federally qualified or lookalikes, to make sure that people are getting not only sort of the mental health and addiction services, but also their primary care services. We know there's incredible overlap between the needs in those populations, and I think have providers always telling me that it's quite often they have someone walk in their door who's had a mental illness for 10, 15, 20 years, or has a severe and chronic addiction disorder they've been using for 10, 15, 15, 20 years. The first time they've ever seen an oral health provider, the first time they've ever really seen a healthcare provider is a mental health or addiction provider. And so how do they get them connected to those services? Because a lot of, the capacity within sort of the mental health system and the addiction system, which I think is, where they're still very separate, addiction providers I think are very far behind sort of on the primary healthcare side. So it's something else that we've been doing a lot of work on as well, and actually partnering with community health centers on. So behavioral health is vital to overall health. I think that, there's sort of one thing that we can walk away with, or maybe not one, but one of the three things, how about that, that we can walk away with. I think that sort of this permeates in some level the general public's conversation. We have the Surgeon General's report, the President's New Freedom Commission, Institute of Medicine. I think all have issued reports that agree that mental health and freedom from addictions are vital to overall health. Effective treatments exist and recovery is possible. I think that this is an area that we have a lot of work to do as far as providers and consumers of services. I think, unfortunately, still in the public eye, our faces are faces of our failures and not our success stories and not our recovery stories. And I think that's something that we spend a lot of time thinking about. How do you sort of highlight that people do get better, that addiction treatment services, mental health services do work, that people recover and do really well in their lives. And we know that treatment, as far as mental health and addiction services, it leads to reductions in overall healthcare costs and utilization of healthcare services. That again, they are really linked. Without sort of thinking about behavioral healthcare issues, you're not going to really fully accomplish healthcare reform, whether it's through records, care, insurance reform, et cetera. A study done, I think this was in Washington State, actually showed that a health maintenance organization reported a 30% reduction in medical care costs among Medicaid patients who had been, we're getting calls from providers. We're anticipating a 40, 50, 60% reduction in the amount of services that we're going to be able to provide. This on top of places that often have a month, 3 months, 6 months waiting list. So you're talking about families in incredible crisis. They finally get to the point where this person is going to seek help, and the response in the end of the phone is, well, have they been arrested? Okay, well, if they haven't been arrested, tell them to call back once a week for, the next month, and hopefully we can get them a bed. So just sort of, situations that we should not be putting families in. And again, feel healthcare reform presents an incredible opportunity to deal with some of these things. Again, just a few more stats from studies that have been done to sort of underscore how important it is to address behavioral health in terms of overall health. Each year, substance abuse and dependence affects more than 1 in 8 Medicaid beneficiaries. Diagnosed psychiatric and substance use disorders are from 50% to 100% more prevalent among Medicaid beneficiaries than in the general population, and 25% of all hospital admissions have been shown to have been tied to a mental illness or an addiction disorder. So I think these are conversations that we often don't have. I think in terms of healthcare reform, in terms of the stimulus, very little conversation occurred around behavioral health issues, and how do we make sure that we're including those providers and those individuals in the conversation, and we, for the most part, were not included. So I think to sort of look at these sorts of, look at these stats and to think about that we're arguably moving along with with addressing some of these issues in terms of, regular healthcare, primary healthcare, and not thinking about the implications of behavioral health is really, again, going to leave us with an incomplete picture. Again, just want to underscore, I think, Mike and I talked about it. It might be helpful for those of you that don't sort of live, sleep, eat, breathe these issues like I do, sort of a sense for the background and sort of how many people, the cost of not treating these illnesses are affected. Just looking at drug and alcohol abuse, the cost every year of not treating it, exceeds $275 billion a year, including lost productivity, medical expenses, crime, and other costs. More than 23 million people are in need of addiction treatment services, but only about 2.4 million receive it. So only 10% of people, are receiving services. So again, we know where these people end up. They end up in the free clinics. They end up in the emergency rooms. They end up in our jails. They end up in our homeless shelters. They end up in our streets. So we're paying for people anyways. It's, more about how are we going to pay for them and how do we get our most bang for the buck, and not treating it has been shown obviously to not do that. Common disorders. I think it's something people sort of, if you haven't been personally affected by mental illness or addiction, you sort of, oh, those are those fringe illnesses. But if you look at sort of the sheer numbers of people that are impacted, 16% of adults, 30% affected by a mental health problem. And, the Substance Abuse and Mental Health Services Administration has come out with a stat that said that 1 in 4 kids is affected by addiction. 1 in 4 kids is affected by substance abuse or dependence. And so, again, sort of the breadth, reach of these issues is really incredible. And then the last stat, the individuals with serious mental illness, because of not receiving health care and complications from their care and some of the meds that they need to take in order to stay stabilized, die on average 25 years earlier than people without mental illness. If you look at people with addiction disorders, it's about a 22-year, they die about 22 years earlier. So turning to sort of HIT and behavioral health care and what's the current status, sort of the other part of my job here. We have done recently a study in partnership with a number of other sort of mental health psychiatric care systems and have some information about the current status of HIT and behavioral health care. In general, I think it's very sad and very lagging behind, and that's part of what I'm going to talk about. On average, the total spending for information technology seriously lags behind what is happening in terms of healthcare. Obviously the lack of funding in terms of stimulus dollars did not help that, and is probably going to further increase that divide. I think combined with sort of what's happening on the state budget level, again, the reliance that a lot of our providers have on state general dollars. They're really hurting right now. The need for IT resources far outstrips the current levels of support. Some of the respondents indicated that if resources were available, that overall IT spending would increase by about 15%. And if you look at what they're budgeting for and what they're anticipating as far as budget cuts, that they're expecting sort of a 15% budget cut over the next year in this area on top of the 15% that they would need to do what they need to do. So, in general, there's almost a 30% difference between the expected spending and the needed spending. So again, a serious lagging behind around what needs to happen. And I think, again, we'll talk about this a little bit more, people realize this is important to do. People would spend money on this if they had it. I think it's a similar situation. Is it, EHR, or is it, take care of another however many patients this year? And I think you're still going to, for the most part, people are going to err on the side of taking care of patients. And so I think that's something else that needs to be pointed out. The last bullet, the level, for those people that do have it, the level of interoperability with both primary health care and public health is in its formative stages. While we do have some community mental health systems that are moving forward and adopting a variety of different EHR software systems, there are a variety of different EHR systems. And so few community mental health organizations are able to electronically share EHR information across providers. I think that's the other thing that study found. Extremely limited awareness about and belief in the importance of participating in a regional health information organization or a health information exchange. This is about a year old, so we think, given sort of all the conversation over the last 6 months, driven in part by the stimulus and ARA and high tech, that is probably much higher now, and people are really starting to catch on that this is something that's really important. They need to know about, they need to care about. But again, I think it sort of underscores how far behind in a lot of ways behavioral health providers. We do know that states are sort of in a range of places as far as working on some of these issues. We know that 14 states have reported that they are working with a regional health information organization to get mental health included in plans for electronic exchange of EHR, but few states are currently able to share their EHR data. 18 states have reported having EHRs that permit sharing between state psychiatric hospitals within individual states, but only 5 states report that they have agreements to share EHR data between state hospitals and community providers. And that's just sort of this issue of people bouncing sort of between systems. They arguably are different systems. While you have some places that have, more levels of acute residential care for psychiatric crisis, for the most part they are separate. And so you don't even have those sort of systems where people may be moving between them, not even able to share information. I heard Oklahoma recently is trying to tie together not only the behavioral health systems, but to the criminal justice system. So they have some sense for the people that are bouncing between the two in an effort to sort of get at how you take better care of these people and sort of prevent the bouncing between the systems.